So, are you sitting comfortably? Fantastic. I hope you had a lovely lunch. It was absolutely delicious. I'd now like to start for the afternoon program and introduce our first virtual presentation by Sharma Charania, and she's going to be talking the impact of dysarthria on the participation of daily activities and psychosocial well-being in people with MND.
Today I will be presenting the data from my study investigating the impacts of communication impairment on the ability to participate in daily activities and psychosocial well-being in people with MND. Before I begin, I would like to acknowledge my supervisors and co-authors listed here for their support and guidance throughout my PhD. I would also like to give a special thank you to the Prince Charles Hospital Foundation for believing in my work and awarding me with a PhD scholarship. Dysarthria is one of the most distressing and debilitating symptoms of MND. While we know dysarthria to be an initial symptom in 25 to 30% of MND cases, 90 to 95% of people will likely experience verbal communication difficulties at some point during disease progression. Features of dysarthria include decreased speed, range, tone, accuracy, and/or steadiness of movements in the respiratory, phonatory, articulatory, and resonatory speech subsystems. Progressive impairment to one or more of these speech subsystems can lead to alterations in naturalness of speech and intelligibility, and eventual loss of functional verbal communication. Furthermore, we know dysarthria impacts communication effectiveness in people with MND, and therefore restricting the ability to participate in activities of daily living. Reduced ability to use speech or speech loss can therefore negatively impact on social interactions and vocational roles for people with MND. As living a passive or more isolated lifestyle leads to feelings of frustration, isolation, control issues, and negativity, people with MND are likely to experience an impact to their psychosocial well-being. However, no studies to our knowledge have investigated change in communication effectiveness and psychosocial well-being in people with MND over the course of the disease. Therefore, our study aimed to map the deterioration and changes in communication effectiveness and psychosocial impact of dysarthria in people with MND over a 12-month period from the early stages of the disease. The object of the study was to provide an understanding of the importance of patient-centered management for people with MND. A longitudinal prospective cohort methodology was employed for the study. Convenience sampling was used to recruit 6 people with MND from the MND clinics within the Queensland Health Metro North Hospital and Health Services. Participants were eligible for inclusion if they received a formal diagnosis of MND in the previous 6 months and were able to provide informed consent. Individuals who were 7 months post-diagnosis or later, or presented with a severe cognitive impairment, dementia, or other substantial medical, neurological, or psychiatric disorders, or were not proficient in English, were not eligible to participate. Participants were assessed at 5 time points at 3-month intervals over a 12-month period. Sessions were conducted either in a quiet room at participants' homes or at the University of Queensland. Each assessment session consisted of the completion of a perceptual clinician-rated assessment and patient self-reported measures. The ALS Severity Scale speech subsystem is an ordinal staging system that evaluates functional verbal communication. The clinician conducting the study rated participants on a scale of 1 to 10 using a conversational sample. 1 indicated non-vocal and 10 indicated no impairment to speech. The Study M incorporates social situations relevant to people with MND. Communication effectiveness for 10 social situations was rated by participants using a 7-point Likert scale, with 1 indicating not effective at all and 7 indicating very effective. The Depression Anxiety Stress Scale is a 21-item self-reported measure used to determine overall mood. It includes 3 scales along the axes of depression, anxiety, and stress, with 7 items per scale. Participants rated the extent to which each state was experienced over the past week using descriptors correlated with numeric values on a 4-point scale, with 0 indicating never, 1 sometimes, 2 often, and 3 almost always. Severity of depression, anxiety, and stress symptoms was determined by summing the score for each scale and using the clinical cutoff scores. The dysarthria impact profile quantifies the psychosocial impact of acquired dysarthria from the perspective of the person with MND. The DIP consists of 48 items across 4 domains. Participants responded by ticking strongly agree, not sure, disagree, or strongly disagree to each statement or item. Numerical values were assigned based on how negatively or positively the items were worded. Then the total DIP score was calculated by summing the domain scores. Low total scores indicated major negative impact, while high total scores indicated minor negative impact. For the 5th domain, or domain E, participants were required to write up 4 concerns or worries in addition to their dysarthria. Thereafter, the concerns and worries were ranked in addition to speech difficulty from 1 to 5 based on level of concern, 1 being most concerned and 5 being least concerned. Descriptive statistics were used to observe clinical trends in data over the 12-month period. Due to the small number of participants, non-parametric statistical analysis was used. The Friedman's test was employed to test for progression, while significance was determined using a p-value of 0.05. Where significance was identified, post-hoc analysis between the first time point and subsequent time points, as well as interim time points, was conducted using the Wilcoxon-signed rank test. A p-value of 0.05 was used to determine significance. To identify the biopsychosocial impacts of MND on participants' functioning, open-ended responses from domain E of the DIP were mapped to the ICF, or the International Classification of Functioning and Disability, using a crosswalking or linking methodology. The steps of crosswalking involved identifying meaningful concepts in participants' open-ended responses of the questionnaire, mapping the concepts onto relevant ICF domains including body function, activities and participation, and environmental factors, and coding concepts to more precise ICF categories where possible. Responses that did not fit within the ICF were provided their own code. Items were only coded once, and accuracy of coding and categorization was checked by 2 other team members and speech-language pathologists. At baseline, we see a median score that demonstrates obvious speech changes for the group. Furthermore, a significant reduction in functional verbal communication was observed over the study period, with median values for each time point showing a gradual decline over time for the group. However, the range highlights that not all participants experienced a reduction in their verbal communication. Post-hoc analysis revealed a significant change to functional verbal communication within the first 6 months of the study, and that changes in functional verbal communication occurred within 3-month intervals throughout the 12-month study period. Mild to moderate impairment to overall communication effectiveness in the early stages of the disease was observed, with deterioration of overall communication being significant across the study period. By the last time point, communication effectiveness became moderately to severely impaired. The ranges across each time point indicate all participants experienced some level of reduced overall communication effectiveness, despite 1 or more participants having functional verbal communication. Post-hoc analysis baseline comparisons revealed significant decline in overall communication effectiveness within the first 3 months of the studies and subsequent time points except time point 5, or the last time point. Interim time point comparisons highlighted deterioration in communication effectiveness within 3 and 6 month intervals. Descriptively, communication effectiveness declined across all social situations over the 12-month period. Deterioration over the study period was significant for all social situations, with the exception of having a conversation with a stranger over the phone and speaking or having a conversation before a group. It is important to note that the median scores at baseline indicate communication effectiveness while having a conversation with a stranger over the phone and before a group were mild to moderately impacted, with ranges indicating 1 or more participants experienced a severe impact to their communication effectiveness while participating in these social situations. Median baseline scores revealed communication was most effective with a familiar person or stranger in a quiet room and over the phone with a familiar person. The score range for conversing with strangers in a quiet environment revealed that all participants experienced some level of reduction in communication effectiveness. Conversely, communicating at a distance and in a noisy environment were least successful, with communication effectiveness being moderately impacted at baseline, with all participants experiencing some level of difficulty communicating effectively in each environment. By the last time point, communication effectiveness while having a conversation with a familiar person and stranger in a quiet room and having a long conversation were the most successful, although still mild to moderately impacted. By the last time point, communication effectiveness was severely impacted while having a conversation with someone at a distance, in a noisy environment, and over the phone with a stranger. Post-hoc analysis baseline comparisons revealed communication effectiveness in 7 of the 8 social situations declined over the first 9 months of the study. Post-hoc baseline analysis revealed communication effectiveness deteriorated significantly while having a conversation with a familiar person over the phone and while having a long conversation within the first 3 months of the study. Furthermore, significant deterioration in communication effectiveness occurred while having a conversation in a quiet room with a familiar person and stranger, with young children, and in a noisy environment within the first 6 months of the study. Symptoms of depression, anxiety, and stress did not progress significantly. However, median scores indicate detectable symptoms of anxiety at baseline, while symptoms of depression were detectable at the last time point. At the 3, 6, 9, and 12-month time points, individual scores indicate 1 or more participants were experiencing either mild or moderate symptoms of depression and/or mild symptoms of stress. Furthermore, 1 or more individuals presented with mild, moderate, or extremely severe symptoms of anxiety across each time point. Progression of overall psychosocial impact of dysarthria was not significant. However, median scores reflect a moderate impact on overall psychosocial well-being throughout the 12-month study period. Furthermore, the ranges at each time point indicate that all participants, including those with functional verbal communication, experienced some level of reduced psychosocial well-being throughout the 12-month study period. Descriptive analysis shows dysarthria had a moderate effect on the speaker at baseline, with severity of impact increasing significantly over the 12-month study period. While dysarthria continued to have a moderate effect on the speaker at the 12-month time point, the impact ranged from moderate to major across participants. Post-hoc analysis showed a significant effect of dysarthria on the speaker within the first and last 3 months of the study. A total of 101 worries were disclosed by participants, with the most reported worries across body function, activities and participation, and non-ICF factors. Detailed worries are listed on this slide. Overall, our results support the need for holistic and patient-centered care. Early and/or rapid changes in functional verbal communication, communication effectiveness, and psychosocial well-being shown in the study indicate the vital need for early and continual engagement of speech-language pathology services. Furthermore, communication effectiveness is likely a key clinical marker needed to anticipate and track reduction in communication participation from the early stages of MND. Subsequently, an understanding of social situations facilitating or impeding communication effectiveness is important in tailoring management strategies with disease progression. As 1 or more participants with functional verbal communication presented with a reduction in communication effectiveness throughout the study period, it is likely factors beyond speech impairment are impacting communication effectiveness, such as hearing impairment and/or fatigue. Therefore, considerations of factors beyond dysarthria identified by people with MND need to be considered when providing communication management. Psychosocial well-being was impacted throughout disease progression for all people with MND, irrespective of dysarthria presence. Furthermore, Domain E results from the DIP show worries in addition to dysarthria. Therefore, close monitoring of overall mood and psychosocial well-being is required to make timely and relevant referrals to members of the multidisciplinary team. Limitations of the study include inability to capture insight from MND symptom onset, and due to high attrition rates of people with MND, the study had a low number of participants. People with MND experiencing cognitive changes or frontotemporal dementia were also not included in the study, and while the study captured vital information on communication effectiveness and psychosocial well-being, the experiences of people with MND were not addressed. Therefore, it is suggested that future studies include a large number of participants, people with MND who have cognitive changes or frontotemporal dementia, and the experiences of deteriorating and/or changing communication effectiveness and psychosocial well-being throughout disease progression. Thank you for listening to my presentation today, and I am very happy to answer any questions on this forum or through the email that's provided on this slide.
Thank you very much, Salma, for a really important study, I think. And I think it would help us to plan and anticipate problems that may arise for patients as the disease progresses. Are there any questions for Salma? There's one in that far corner. Salma, while they're just going to take the microphone, I just wondered if, and it's not something you might have thought, but men and women clearly often, I mean, I suppose anecdotally kind of communicate in very different ways. Did you notice any difference from your study between the men and the women?
It's hard to tell or talk about it because we only had 2 females and 4 males. So to get a good insight on male versus female presentation, I think we need a bigger number. But with that being said, part of my PhD or part of my research actually did have a qualitative component, and in saying that, the women did disclose that communication had more of an impact on them and the way they decide to participate in daily activities.
Thank you for that. We have a question from over there. Just changing the microphone.
Thank you for the presentation. I had a question with regarding to interventions. You followed the participants for a year. Were those participants intervention naive, such as speech computers, or did you took that into account as well?
Yeah, absolutely. So in this particular study that I presented, we did accommodate for take into account whether or not the person was accessing the AAC device. But at a later study that I did, we did account for the AAC device being used by some participants. Majority of participants in the study actually weren't using an AAC device, and again, during the interview process, all of them wanted to complete voice banking, but never did due to the difficulty of the process. So I think, and again, it's been a few years since I collected that data during my PhD, but I believe that it comes down to how much their allied health professionals knew and when to introduce certain types of interventions for them.
Thank you.
We have time for one more question. If there's anybody, any online questions? Nope. Lovely. Salma, thank you very much for your presentation.
Thank you.
I'd now like to introduce you to Jennifer Bedford, who is going to talk to us about evidence-based care, a review of the NICE guidelines for motor neuron disease.
I might that podium. I wasn't really sure how to get up on the stage then, so yeah. And hopefully you can see me because there's a lectern in front of me and I'm very small. But so I'm Jen Bedford. I'm from the M&D Association in the UK. I'm Head of Partnerships, Education and Information. And I'm going to talk to you today about the NICE guideline for M&D and the review that we've done of it recently. Well, over the last year, really, I would have to say. And how do I move things on? Okay. Right, so just to start really with a summary. So the NICE guidelines are produced by the National Institute for Health and Care Excellence, and they're evidence-based recommendations for health and care in England. They're also applicable in Wales and Northern Ireland. And they set out the care and services that a person living with MND should expect from their care. And the aim is to help prevent ill health, at the risk of reading directly from the slide, promote and protect good health, improve quality of care and services, and adapt and provide health and social care services. So it should lay all that out, and part of our literature that we have is a guideline for people living with MND about this and what to expect from their care, and we have a short piece of information about that, so it's very important to us from a patient perspective, but also for professionals that are providing the care for people living with MND. So they're quite key things for us. So the reason it came under our scrutiny was it was first published in 2016. And NICE guidelines should be reviewed every 5 years. That's the cycle of it. And we got to 2021 and there was no sign of it being reviewed. So we felt that we would have a look at it ourselves. The issue that we've got is that MND is quite a rare disease, and also there are quite, for that reason, there are a small number of people with it. We're very lucky to have the guideline for this condition. So it was updated last July 2019, and not a great deal was updated on it. So in terms of the research that goes on, and I think we've heard that from many of the presentations already, we have small studies, small study numbers, and we can't do the kind of research that NICE is kind of looking for really in terms of randomised control trials, etc. So NICE set quite a high standard for their evidence that they can put into the guidelines. So in terms of getting a NICE guideline updated or for it to come to NICE's attention, they carry out what's called surveillance, and they aim to check the guidelines are up to date, but there are many, many hundreds of guidelines. So we feel it's important for us to keep an eye now on and make sure that we're there representing the people living with MND to the people at NICE to say, hey, things are changing out there, and we need to do the best we can to make sure that guideline is updated and that professionals have the latest information about how to best care for people living with MND. What would trigger a review for NICE is to new evidence which contradicts what's already going on in the guideline, a new intervention that might come out, and contextual changes such as policy. So an event would be a direct publication of a study that's bringing out completely different information that's in there. And what happens if there is an event is that triggers a topic expert panel to come together. They would do a literature search and they would look at all the intelligence that's out there. So a big process starts at the point where it's identified that there may be something that needs to change within a guideline. And clearly that wasn't happening. So what did we do? We convened our own expert review group made up of a significant number of eminent professionals in their field. So we decided to go right to the horse's mouth, talk to people about what was going on and what had changed. We did a literature review of our own and had a look at what was going on out there, and we considered all of the areas of the NICE guideline. To start off with, we looked at the things that NICE were most interested in. So back in 2016, when they wrote the guidelines, there were some areas they were particularly interested in, and they said they had their eyes on, if you like, around it. So we particularly investigated those ones because we thought they're already interested in that, so maybe they'll listen to us if we can find some changes. So there's organisation of care. They were interested in the network-based model versus the clinic-based model. They were interested in cognitive assessments, impacts of cognitive assessments, how often they should be repeated, etc. There was a prognostic tool at the time. They were interested in that and how that was going on. Saliva, how are we managing saliva? Interesting, AAC. We've had a lot of talk about AAC today. They wanted to know what the pattern of provision was like for AAC. Nutrition, as a high-calorie diet, affects survival. Exercise prescription, that's a perennial one. I'll come back to that one later. And also peak flow cough augmentation. So they were the ones that NICE were particularly interested in. So we had a focus on those to see what we could find. What we found was not a great deal more evidence, to be perfectly honest. Unfortunately, what we couldn't do was pull together something that was an absolutely compelling argument that we could put to NICE. However, that said, when they first wrote the guideline, one of the considerable things that they did was rely on professional consensus opinion. So using the evidence that is out there, using the professional consensus opinion of the expert topic review group that they had in the first place, the guideline development group, that's how the consensus came. Look at the evidence that's available and take the professional consensus view. So we decided to present our evidence in the same way and to be able to say to them, actually, have a look at this and see what you can consider. So the areas of interest that we came out with after we did our review, we felt that information and support at diagnosis, we felt that had probably moved on. And the reason we felt that had moved on was because of genetics and the genetics question that we now have. There's a lot more information we have around the prevalence of genetic causes and also how to interact with that once that's happened. So what we'd like to see, we're still in the process of interacting with NICE, I should make that clear, we haven't stopped. We wanted genetics listed in what a neurologist is able to talk about to somebody when they come in first with their diagnosis of MND. It's clearly something that's important to people living with MND and their families. So that's what we asked for. We also think that there should be the process for counselling and testing laid out in there as well, so people really know what they can expect when they go for that dreadful first interaction with a neurologist in many ways. Cognitive assessment, what we want, there are now validated tools for cognitive assessment. We feel those should be listed in the guideline. The prognostic indicator that they had at the time fell by the wayside, but we do now know that potentially cognitive and behavioural change can be a prognostic indicator, and we feel that should probably be listed as well. We'd like, in the organisation of care section in the NICE guideline, to have a psychologist listed in the MDT that's supporting somebody living with MND. There's lots of studies that are ongoing, I have to say, that are showing and demonstrating. I mean, it's fairly obvious it would support somebody if they had a diagnosis such as MND, that psychological input would appear to be, I would say, a logical thing that you would expect to be there. We also feel that people may be aware of it in the room, the COMMEND study that's gone on, for example, around psychological support. We felt that there are some specific interventions that could now be listed in the guideline. Communication, when we looked at communication, we found there's a real paucity of evidence supporting communication and why it should be there. It's obvious. We know why communication should be made more available to people living with MND and the interventions that should be there. But actually, there isn't much evidence to support us being able to make that case. What we did ask for was for them to consider that early intervention, getting someone to bank their voice or message bank early on in the process seems to be a logical thing that we should be able to ask. It's done for something like PEG. Why can't it be done for communication when communication is so pivotal to people getting the right therapies in place? So that's what we want to get to that point with. Cough augmentation. We felt that there should be some acknowledgement of the impact of cognitive and behavioural change on the ability to take part in cough augmentation, and also the care burden for somebody supporting someone having cough augmentation. So we found things that we wanted to know, really, is what we came out with. So what response could we make to this? So we sent in a report to NICE, and we've registered all these things that we're really keen to see change. And we're waiting for, as I say, we're ongoing that process, interacting with NICE. But what do we do now? So I think this is the thing going forward. We can take two responses, we think. We want to create more events, and by that we mean let's have a look at the research that's going on out there. Let's make sure the research actually meets NICE criteria, or we can bring it all together, and I'll talk a bit more about that in a second. And we also think there's a place for practical pathways, and we've heard a lot of those today in the room around how the actual care is being delivered out there. There are lots of good practice. Let's share good practice. We also set out some research priorities that we wanted to cover. So we looked at the whole guideline, and we've identified, this is with the, I should say again, with the topic expert that we worked with, we identified sort of research questions for all of the NICE guideline areas, actually, but then we undertook a process of what are the research priorities? What do we really want to see in these areas? And I will... It's not just us in glorious isolation, I have to say. So this is a starting point. So we felt that, and the numbers by the side of it are the recommendations in the NICE guideline, if anyone's wondering why I put 1.8 followed by 1.3. So 1.8, pain, secretion management and exercise. We feel that really does need looking at, and we wanted to come at that from two different ways. So the exercise in the guideline currently says you give an exercise program that's suitable for someone living with MND. We've never really got to the bottom of what that means. We don't really know what effective means. We're not going to make sprinters out of people living with MND, but people need to exercise for mental health as well as anything else. So there's a whole thing to unpick there around that. In terms of cognitive change, we now want to say that one of the questions we set there is, how are assessments best used in practice? How often should you repeat them? We know we've got them now. How do we use them? How do we go ahead and use those? Communication, one of the questions that we set there was the importance of communication for acceptance of other therapies. How does it affect acceptance of other therapies? And also things like which bit of AAC works and why. What's the thinking behind it? 1.4 was investigation of new prognostic tools, potential for validation. 1.6 is the psychological side of things. I think I've skipped my slide too far. I'll go back. So are the benefits of a psychology post into an MDT? We haven't got the evidence of that yet. That's what we need to get to. That's what we want to do. What are the effective psychological interventions for carers is another question we thought would be a good question to have answered. 1.13, so cough assessment is peak cough flow a useful indicator to inform the initiation of choice of cough augmentation technique? And also on that one, early intervention with cough augmentation, does that make a difference? So we've got lots of things that we're wanting to investigate. And now I'm going to talk about how we think we might go around that. So we want to steer a proactive research programme that feeds into practice, education, information, which is my area, so the information side of things. And we want to set up research to care groups. So we're running 2 pilots for the research to care groups at the moment, possibly a third one coming along. And what we want to do here is get together the people that are working in these areas, see what's happening, because we know that we don't know everything. But we want to get the people that are working in these areas to talk and collaborate and see what's actually going on. So those questions that we've answered and that we've set ourselves may well be being answered somewhere. And we just want to bring things together. So it's a kind of a jigsaw approach. So if you're doing this and you're doing that, let's get those things together and then we build the evidence base better for NICE. So we start to create these kind of symbiosis really of research that's going on out there, getting people to talk together. The 2 that we've set up, so we've set up one in communication and we set up one around exercise as well. So those are the 2 that we thought, and possibly the third one will be around psychology. The second thing we want to do is look at real-world evidence and real-world data, and that's something that NICE are particularly interested in. And this is an area where we might have some strength because we know that these things work. And if we can use different types of data to show the effectivity of the things that we want in there, we'll be able to use real-world data and evidence to prove it rather than having to wait for clinical trials that sometimes we can't get to the right level that they're looking for at NICE. This is our opportunity really to show real-world stuff that works in there. And the other thing in that space to say is they're also looking at how to use patient experience data, and I think that's really quite exciting in itself. What we need to do with this, though, is present it in the correct way, in a way that they'll accept. So we need to understand what those parameters are that they're looking for so that we can say, well, actually, here it is. Here is the data in a format that you're prepared to accept. And we've also got professional consensus opinion behind it as well. So we're starting to build our cases. We want to develop a community of AHP researchers. So if anyone wants to talk to me about being involved in anything, be delighted. I think if the more multi-centre studies that we do, again, the more we're coalescing things. We all want the same things. This is what I keep hearing in the room when I'm listening to these presentations. We all want the same thing. And if we can work together, I think that's going to be really, really powerful. Other things we're thinking about are practical stuff. So a platform on the M&D Association website, patient decision aids are being made. Let's get those all together. Let's get those in one place so people can find what they need more easily. Sorry, I'm so short, I have to look around the side. So we've got a community of practice at the M&D Association, which brings together allied health professionals to talk and discuss about what their practice is. What we want to do is look at the profession specific in there and talk to them. So, okay, let's talk to speech and language therapists and get those together, find out what's going on in the workforce and talk to them and really start to create those as well. And products and tools, so we want to be able to produce practical things. So whilst the NICE guidelines are great to have, we also know practice goes on anyway, so we want to really try and make sure things are happening properly. And one of those things, for example, that we're looking at is a pain pathway. so a pain management pathway and looking at those. We also want to make sure that we're spreading that information out as well, and that's what the community of practice is about promulgating the stuff that we're producing, not in splendid isolation. And we also want to make sure, obviously, the patient voice is heard, and that comes back to that point of the patient experience data that we'll be able to use with NICE. So thank you very much for listening.
Thank you very much, Jennifer.
You're welcome.
Are there any questions? There is one question just there.
Thank you. That was really interesting. Jo Whitehouse from MND Victoria.
Hi.
In Australia. I'm just curious what advice you would give to countries that don't have best practice clinical care guidelines. And it's something that we're toying with at the moment. And, do you start from scratch in relation to your particular scenario in your country or area, or is it something that you could crib and tweak?
Well, my personal view would be to start with a nice guideline. There's no harm in starting where it is. It's not a bad thing. It lays out everything from information at diagnosis right the way through to NIV care, which is there. So it does cover the things that have been talked about earlier as well. And it's there, and I think that the bones really are there. I think our job as a collaborative is to make sure that we can, for me, it's the implementation of those guidelines. And I think there's potentially a way of almost working backwards if you've got a blank slate and say, these pathways work, and then sort of going backwards. And in that way, you've got the practical stuff, you've got the evidence, we've got the evidence, we can work together to make more evidence. But everywhere's going to be different. So what works in the UK won't necessarily translate. So those practical things, I think, would inform your particular area. But I think the guidelines are they're sort of common sense, ironically, in a way. It's just getting NICE to accept common sense, just demonstrated by evidence, I think. So,
hello. I'm Dr. Rick Nelms.
oh, hi.
And I'm a biologist from Cambridge and an artist. But the main reason for asking a question is that we have had a lot of experience with the hospice movement, and particularly with the living well care over a period of time. And it seems to me that there's an opportunity to build stronger connections between what you're trying to do and the evidence which can be collected through hospices.
Oh, I agree. I think we do work in partnership with a number of hospices. We've got some flagship hospices, particularly. I'm thinking of Loros, particularly there, where they're virtually an MND centre in all of themselves. And I think, Rick, this is where we're moving. That's the patient data, isn't it, for palliative care?
Yeah,
that's where we can look at what the patient journey has been, and I think that's where the strength lies. Absolutely agree.
Okay, thank you.
May I just check if there's any questions online? No? I think anybody else in the room? No? Well, thank you very much. Thanks, Jennifer.
Thank you.
So I'd like to introduce the next. It's a virtual presentation, and it's by Gioia Chiani and Gary Grimaldi. And I'm really looking forward to this because it's my little area of interest. It's a living experience of people living with ALS with a percutaneous endoscopic gastrostomy PEG feeding tube.
Hello, this is Gary Grimaldi, Assistant Professor of Occupational Therapy at Iona University in New York, and my colleague, Gioia Chiani, Associate Professor of Occupational Therapy at Hofstra University in New York, would like to share our most recent publication on the lived experiences of people with amyotrophic lateral sclerosis with percutaneous endoscopic gastrostomy feeding tubes. ALS is a very progressive disease. There is no cure for it. It impacts the motor neurons in the nervous system, where people demonstrate spasticity, bradykinesia, muscle weakness, and atrophy. 85% of the population also have been diagnosed with dysphagia, the inability to swallow appropriately or difficulties in swallowing. With this said, it leads to poor caloric intake, which again, their body mass index will go down as calories are not taken in. So at some point, patients are faced with being asked regarding a PEG tube placement, which is an alternative means of feeding, and it is an invasive process. So the question that we had for our study was, how do people with ALS describe the decision-making process in obtaining a PEG feeding tube? How do people with ALS describe the experience of obtaining a PEG feeding tube? And what were the influences that impacted the decision to accept the feeding tube? We know from the literature review that most literature is from the medical model. It describes the device, the cleaning of the device, the procedure of the device, right? But there was very little literature on how people come to making the decision to actually obtain a device. Additionally, there was a lack of conclusive evidence to determine the optimal timing of a tube placement. When should it be done? There was conflicting reports on that, although it was outlined that from a medical standpoint, when it would be needed, but again, it was conflicting. So in the literature review, again, it didn't really reflect a client-centered approach from the team or the individual being part of a team. So our method we used was a phenomenology approach. So we looked at the lived experience of individuals, and we had 5 individuals in the study, and we wanted to look at the lived experience, right? From their standpoint of how did the decision to obtain a PEG come about? What was their journey in obtaining a PEG? So again, it was a qualitative design, selective sampling of all 6 participants came from an ALS support group. They all spoke English, and they currently, or they were at the time of interview, utilizing a PEG that they recently had placed. Data collected was through 2 semi-structured interviews. The first interview developed significant statements where themes were developed. The second interview were with the participants just to confirm what they said in their statements. This actually increased the trustworthiness and the rigor of the study with doing a member check. So if we look at our themes, there were 5 themes in the study, and the first one was survival. When we look at survival, people were psychologically fear of choking, and it became apparent. They felt that if they did not get this, they were going to be able to choke, as some of them were having trouble swallowing. The second theme was scary anxiety-provoking process. The reason that came up is that there was a lack of education and information from the medical team, as some medical teams conveyed that this was such an urgency to receive a PEG, even though there really were no signs of swallowing. Also, this theme was developed based on the medical teams, or at least the participants felt that the medical teams were very assertive, or maybe even too comfortable in having people obtain PEGs when maybe it wasn't the right time for them, or they weren't having symptoms of choking. So this idea of that you need a PEG really heightened anxiety, should they get it right away. Also, participants said they wanted to live longer for their grandchildren and be part of the family. Engagement in life activities, how was that going to be impacted by having a PEG tube? When we look at leisure skills, going on vacation, ADLs, that was a concern. But lastly, participants conveyed that they were not alone in the decision, that they had family and they did have medical teams help them make that decision. So they were not alone in it. It was really the individual's immediate or extended family helped them with the knowledge to make the final decision of an invasive procedure. Other areas that came about were areas of ADL, the impact of dressing. Will the PEG tube fall out during dressing? Health management was important. People felt that they were not part of the decision-making team. They lost their autonomy because nobody asked for their opinion. And of course, what was the impact on rest, sleep, leisure, and social participation? How would a PEG tube, impact their lives? And finally, patients also, or individuals or participants, did discuss the psychosocial factors of coping with such an invasive device on a daily basis. The fear of choking. So these were all important factors that came out of the study. So if we look at the results and qualitative comments, the comments were on a wide array or scope. So somebody mentioned, I miss going out to eat with my friends. I can't manage feeding anymore. Getting dressed is really scary. I did it for my daughter. I wanted to be here longer for her. At first, it was brutal. I was completely freaked out psychologically. Or they wanted me to do it preemptively. I did not want to stop eating. I was concerned that I could no longer eat my favorite food. I mean, my gosh. It was simply life or death. These were the qualitative statements that help build the themes that we have in the study. So when we look at our discussion, we found that making or obtaining a PEG tube is not taken very lightly. It's made with many people involved, family members, caretakers, spouses, adult children to extend the family, and of course, the healthcare team. We also felt that it's important to understand the factors that influence people in making this decision. Are they making the decision out of fear? They don't need the tube right now. How did that whole decision come about? And also we looked at timing is crucial in initiating and planning the placement of a PEG tube. When should they have it done in their life? Because again, it is so invasive. At what point do they really need it? And then how that comes about. But one of the major things that came out, and it was across the board, that patients or participants did not feel they were well educated on when the tube should be placed, the steps involved in the tube, the care involved in the tube, but rather it was just, okay, the health team said that I need it, so I need to get it. So again, better education from the healthcare team would be much more important for the individual to receive, than not to receive any or very little. Now, patients did report, those who had their tubes or the PEG tube placement, that there was an improvement in quality of life. They did not have to worry about choking anymore. It was not a concern at all. But again, that client-centered intervention idea needs to be reiterated with patients and the healthcare team, that they need to be included in the final decision on PEG placement. And if we look at our implication for practice, we looked at healthcare professionals have such great knowledge to share about a PEG placement with patients. And we have the ability to enhance participation in life activities by talking about or telling people about the pros and cons of having a PEG placement. It also increases health management. Again, people making their own decisions. Our health team can do that, where people, they don't feel they've lost their autonomy. something that we can also do is increase our education on the PEG tube management for safe ADLs and self-feed-in, that people have a good understanding of. They won't be they won't have that fear or releasing them of the fear of choking. And again, maybe providing psychosocial interventions or recommendations when appropriate. Again, this will again help people in understanding or making the decision in the placement of such a invasive device. Here's our references, and also we'd like to thank you for participating and hearing our study today. If you have any questions, please let us know. We'd appreciate it. And we thank you both or all for your time. Thank you.
Gary, thank you very much for your presentation. You didn't know you had spoken such a short time. You've got time for a lot of questions. But while we're finding questions in the room, I have a question for you that made me think while I was listening to your presentation. As healthcare professionals, do you think, we're talking to patients, we're talking about the timing and things of a PEG, do you think there's an element of unconscious bias that we may put towards our patients about that? Is that anything that came out? Or we try to stay neutral, but I wonder how neutral we are.
What I found from the study from the 5 participants was basically, I think there is some type of bias there. I think that from what the participants shared with me, the education part was that it's almost like for a doctor to say it's second nature. Well, you need a tube, you need a PEG placement, or you're going to need one eventually. You might as well get one now. In the case of the study, I did have one person who the doctor just said, I'm going to schedule right away for a PEG placement. However, the patient had exhibited no signs of choking at all. So I think from the 5 participants, what came out of it was healthcare professionals at the medical level may be very comfortable with just saying, you need it, or you need it eventually, so you might as well get it now. And that was a major concern. But what the 5 participants shared was that, they didn't want to go against the doctor's orders to say, well, if the doctor says I need it, then I need it. If the doctor said I didn't need it, he wouldn't be recommending it. But it became from the data, as the data came alive, was that it's just basically it's second nature for a doctor, and patients weren't really involved in the decision in some cases. So I think, as you said, there could be a bias here that, down the road they're going to need it, so you might as well get it now. Why wait? That's what I found from interviewing the participants.
Yeah, that's very interesting. Thank you. Are there any questions in the room? Any questions online? Oh, yes, I beg your pardon. Yes, sorry. There is a question.
Hi, David, a patient fellow. So we had a really interesting presentation this morning on food preparation that makes it easier to swallow. And then there was a conversation after that about nutrition value and cutting food small versus doing the preparation with the filler materials, I forget what the word was, versus going to PEG. So I guess, as someone who's not an allied professional, is there any kind of guideline for how a patient progresses through those different stages of nutrition while maintaining quality of life?
Okay. In terms of nutrition, I did not find any guidelines regarding that. Basically, there were guidelines found in the literature of when somebody may need a tube, but they're very inconsistent across the literature at what point somebody would need a tube. It's not really standardized, and I could see the point it's not standardized. Everybody's different, but I think something has to come out where patients understand if you're at this level, this is when you're going to need a tube. And not to say it wasn't there, it was just inconsistent when you read the literature of at what level. Again, regarding the food that you mentioned, I'm not aware of any standard that or progression of different types of food. Most of the people in the study were eating, well, actually, their family were cutting the food at that point, and they were still having problems like choking or were afraid to choke. That's basically what I know about the nutritional part of it as an occupational therapist.
Thank you. Oh, there's another question.
Thank you. My name's Margie. I'm a physiotherapist from Australia, from Calvary, Bethlehem. I was just curious, did you look into the diagnostics around lung function tests as well? Because we often find people going for PEGs, it's not always their swallow or their nutrition, it's a lot to do with the timing around their lung function.
Correct. From a perspective of interviewing the patients, I didn't explore that. However, in the literature, that was explored. And as I mentioned, regarding lung capacity, some articles mentioned that it should be at this is the standard. If someone drops below this point in lung capacity, they need to be pegged. Versus other studies may have mentioned a different number that the person should receive a peg. And that's when I was talking about inconsistency in the literature. But it definitely was there. However, across authors, it was very different. That's what both my co-researcher and I did find.
Thank you.
Thank you. Any more questions?
Yep.
Oh, sorry, Gary. Are there any more questions? Carry on. Did you want to say something else?
I just wanted to add that the biggest part of the study that came out of the individuals regarding the themes again, that client-centered approach was missing. All of them said that. Although they did find that some nurses in the ALS clinics here in New York were very helpful, but overall, all 5 of them mentioned that they weren't really educated on the PEG, on what's really involved, the follow-up care that's needed, things of that nature. I mean, the families did support them, but I think education was the number one thing as health professionals, as occupational therapists, speech pathologists, nurses, that I think we need to really focus on. That's what I really got out of the 5 people that we interviewed who have been using PEGs for the last 5 years within the study.
That's really interesting. Thank you. I think that's all the questions from here. So I'd like to thank you, Gary, for your presentation.
Thank you so much.
Thank you.
Have a good day. Thank you.
Now, may I welcome to the stage Claire Radcliffe, who's going to talk to us about exercise interventions for people with ALS-MND and a systematic review.
Thank you. So my name's Claire. I'm a physiotherapist working with Calvary Healthcare Bethlehem in Australia. And today I'm going to talk about our systematic review on exercise interventions for people with ALS-MND. I want to acknowledge my supervisors and a big thank you to MND Victoria who funded this review. I also wanted to acknowledge the 910 participants within the studies that were in our systematic review. Without all of these participants, this systematic review wouldn't have been possible. So first, I want to talk about why we felt a systematic review would be helpful in this space. While not all people with ALS-MND feel strongly about participating in exercise, there's definitely a group of people who feel really strongly about wanting to participate in exercise as part of their disease management. So one person with MND said, "I knew there were so many benefits with exercise and I wanted to give it my best shot at keeping my body strong and healthy for as long as possible. It felt like everyone gave up on me when we talked about exercise, and it's frustrating that there's no clear answers." So this group of people really wants to know, should they exercise? What type of exercise should they do? How much exercise should they do? And what effect is the exercise going to have on their disease? So our primary research question was to understand the efficacy of exercise on disease-specific and functional outcomes in people with ALS-MND, and our primary outcome measure was the ALS-FRSR scale, which is a scale of physical function. But also we really wanted to pay attention to the important information in the clinical prescription of exercise. So we wanted to understand how different types of exercise, how people respond to different types of exercise. We wanted to understand how people at different stages of the disease respond to exercise. And we wanted to understand how people with different ALS-MND phenotypes respond to exercise interventions. So I'm not going to go into too much details about the methodology of our review. It's registered with Prospero if you want to look up more details. We included all phenotypes of ALS-MND, so ALS, primary lateral sclerosis, primary muscular atrophy, and progressive bulbar palsy, and any other ALS phenotypes. We included RCTs, non-randomised controlled trials, and we included single group intervention studies because we know it's really hard to recruit participants to clinical trials in this population, and we know there's lots of really helpful clinical information out there in those single group intervention studies. We included all exercise interventions and we included all outcome measures, but as I said, our primary outcome measure was the ALS-FRSR, or a patient-reported scale of physical function. We screened almost 7,000 articles, and in the end we had 31 studies included within our systematic review. So now looking a little bit into the demographics of the people included in our systematic review, all of the participants across all of the studies had the ALS phenotype of MND, and people with other phenotypes of the disease were not represented in the literature at all. We also noted that a lot of the studies had eligibility criteria around physical function. So 36% of studies had eligibility criteria around the ability to walk, 22% had criteria around the stage or duration of the disease, and 39% had criteria around FVC or lung function. Looking again a bit closely at who was actually included in these studies, the mean ALS-FRSR, so functional rating scale of participants, was 38 out of 48. And you can see on that scale there on the screen that within each of the studies, the mean functional rating scale of the participants was towards the higher end of that scale. And the same thing was true in terms of lung function. So the mean forced vital capacity was 88%. And again, within each of the studies, the lung function of the participants was towards the higher end of that scale. So this was really important for us to consider when we were interpreting our results, because a lot of the participants were at earlier stages of the disease and had minimal functional impairment at baseline. So next I'm going to talk a little bit about what types of exercise were included across the literature. We analysed our data based on the type of exercise. So we had categories of aerobic exercise, resistance exercise, respiratory muscle training. We had an other respiratory intervention category, which included things like diaphragmatic breathing, respiratory swallow coordination training was included in that group. We had an other exercise category which included some studies that had robotic-assisted gait training or robotic-assisted upper limb training. And then we had a lot of studies that included more than one type of exercise within their intervention protocols. So we grouped these into a mixed exercise category. Most commonly, these studies included an aerobic component, a resistance component, and a stretching or range of motion component. When we grouped all of those studies together, we saw there was a really clear delineation between studies that had systems or protocols in place to ensure participants were exercising at a moderate intensity. So they used things like a rate of perceived exertion or heart rate monitoring to ensure participants were exercising at moderate intensity. So that group was split into moderate intensity and low intensity mixed exercise. So overall, we found that there were low levels of attrition. The overall attrition rate was 15.85% across the literature. There were really low numbers of adverse events. Only 11 adverse events were reported in total across the literature at a rate of 2.39%. And although it wasn't reported consistently, when it was reported, the adherence to the exercise protocols was high. But important to remember that this was among participants who were at earlier stages of the disease and who had minimal functional impairment at baseline. So I'm not going to talk about all of the results from our systematic review today, just a few of the key exercise categories. Resistance training I'll talk about first. We had 4 studies included within our resistance training group, and you can see there that the attrition and adverse event rates were slightly higher than the overall attrition and adverse event rates. Unfortunately, in this group, there was really varied outcome measures that were used and really varied comparison groups that were used. So that really limited how much meta-analysis we could perform in this category, and we couldn't perform any. And there wasn't any real clear conclusions or trends in how the resistance training affected the functional rating scale, muscle strength, or any of the other outcomes. One of the things that was really interesting in this category, out of all of the exercise studies that included a resistance training component in their protocol, 12 of 16 of those modified their exercise significantly. So some avoided the concentric phase of contraction, some avoided the eccentric phase, and some modified both phases of contraction, or they avoided strengthening weak muscles altogether. So across this resistance training group, there were really conservative resistance training protocols, and particularly when in regards to strengthening or exercising muscles affected by ALS-MND. Next, I'll talk about respiratory muscle training. So this was our biggest category in terms of number of participants. There were 7 studies in this category. Some of the studies used inspiratory muscle training, some used expiratory muscle training, and one study combined both inspiratory and expiratory muscle training. Again, we had a real variety of outcome measures which limited the meta-analysis that we could do, but we could perform some meta-analysis within this group, which I'll show you on the next slide. In terms of the outcomes, though, there was inconsistent results for measures like peak cough flow, swallowing function, quality of life outcomes, physical function, or lung function. But across the literature, none of the studies reported that their outcomes deteriorated at a faster rate in the respiratory muscle training group than they did in the comparison group. The respiratory muscle training groups either performed the same as the comparison groups or slightly better than the comparison groups. So this is the meta-analysis that we were able to perform within this category. We compared respiratory muscle training with sham intervention on the ALS functional rating scale. And as you can see there was no significant, neither of the groups were favoured significantly there. We compared respiratory muscle training with no intervention on forced vital capacity or lung function. And you can see the results maybe slightly favoured the respiratory muscle training group, but did not achieve statistical significance. We then were also able to compare expiratory muscle training compared with sham intervention on maximal expiratory pressure, so a measure of expiratory muscle strength. And we can see there that clearly the results favoured the respiratory muscle training group and they achieved statistical significance. So we showed that expiratory muscle training improves expiratory muscle strength, but whether or not that translates into physical function or lung function is still unclear. Next, I'll talk about our mixed exercise category, so exercise protocols that included more than one type of exercise, most commonly resistance, aerobic exercise, and stretching or range of motion exercises. So in this category, a lot of the studies reported on the functional rating scale, which was really nice. And 5 out of the 6 studies that reported on that scale reported that the mixed exercise category group improved significantly when compared to a comparison group. Unfortunately, there was differences in the comparison groups used, which was one of the factors that limited how much meta-analysis we could perform here. And again, within this category, across all of the studies, across all of the outcome measures, the mixed exercise group either performed the same as the comparison group or slightly better than the comparison group. None of the outcomes deteriorated in the mixed exercise at moderate intensity interventions. So this was the meta-analysis that we could perform within this group. We compared mixed exercise performed at moderate intensity compared with usual care on ALS functional rating scale. And you can see there that the results favour the mixed exercise category and it achieved statistical significance. And the mean difference here was 13.22 points, which has already been established to be a clinically significant level of improvement in this scale. So in summary, we found that exercise is safe, tolerable and feasible for people with ALS-MND. This is evidenced by low levels of attrition, low levels of adverse events and high adherence to exercise protocols. We did find that there were lots of limitations across the literature though, so there was high risk of bias across most of the studies. As we'd expected, there were small sample sizes, and one of the biggest limitations we had in terms of this systematic review was the inconsistency in exercise protocols, the outcome measures used, and the comparisons groups that were used. Given we know it's so hard to recruit enough participants to well-powered, randomised controlled trials, it's really important that researchers consider these factors when designing their trials, because it's likely that these important clinical questions that we have about exercise are going to be answered through future systematic reviews. In terms of our research questions, it was unclear which type of exercise was most effective. We couldn't answer that question, but we could show that mixed exercise at moderate intensity might slow functional decline, and expiratory muscle training might improve maximal expiratory pressure. In terms of how people with different phenotypes respond, we couldn't answer that question either, because only participants with the ALS phenotype were represented within the literature. So more research is needed amongst people with other phenotypes so they can understand how they might respond to exercise interventions. And all participants in this review had relatively early stages of the disease and limited functional impairment at baseline. So this should be a priority for future research so that people can understand how they might respond to exercise across the spectrum of the disease. And finally, I'll leave you with some clinical considerations. So while not all people with ALS-MND feel strongly about wanting to participate in exercise, there's definitely a group of people who find exercise is really important to them and they feel really strongly about wanting to participate in exercise. And this group wants clear, practical, specific information about how they actually should go about exercise. Exercise should be monitored. In particular, high-intensity exercise should be monitored by a health professional because it's not been tested in the literature at all. It's important to consider exercise in the context of the person's life, and as physios, it's important for us to consider and work with the patient to establish if we need to be prioritising meaningful activities and activities of daily living over structured exercise programs. And then finally, it's important to openly discuss the uncertainty and limitations of the evidence so that people with ALS-MND can make informed decisions about exercise within the context of their disease and within the context of what's important to them. Here's our contact email address. Feel free to get in touch if you have any questions or if you need any more information. Thank you.
Thank you, Claire. That was really interesting. Does anybody have any questions? There, question in the room.
This is an online question, and it is, what would be included in mixed exercise?
So our mixed exercise category was the studies that included more than one type of exercise within their exercise protocols. And as I said, most commonly this consisted of an aerobic component, a resistance or strengthening component, and a stretching component. But this was our group that was least consistent in terms of exercise protocols. But we had to group those in together as closely as possible. So that's why we had the intensity element within those categories.
There. Can do one more. Yeah. How has this changed your practice?
I think the biggest thing that it's changed is it just gives me a lot more confidence going into that clinical discussion. It's not that I've been armed with new information about exercise or a new way of approaching exercise. It's more that I've got all the information I need to openly discuss where the literature is, where the evidence is, and help people make the decisions about how they want to use that information.
There's just behind you, yeah.
Hello. I like your considerations, and it brings a question whether you find in your review whether the person liked doing exercising before the diagnosis or the symptoms of ALS. So did they like before? They didn't, probably they would like that. So that is a key question, whether they would like to embrace that. And the second question, if I may add, is in those that did exercise, does the review shows an increase of falls after exercise? And that's something that we call pseudo weakness when somebody fatigued the muscles.
The first question, so clinically, I think, and this is the same in other populations, there's a certain group of people who really identify within their exercise. So they're runners, or they play soccer, or they do different physical activity as part of their identity. Those people definitely feel really strongly about continuing exercise. There's probably also a group who use exercise as stress management, or it's kind of their pre-existing way of going about life. So those people feel really strongly about it clinically. But that's definitely a big gap in the literature. There's not much qualitative information about what people with ALS-MND want to know about exercise and why they want to know it. So I think that would be a good space for future research. And then in terms of the second, could you just remind me the second part?
Sometimes when people do a lot of exercising, they have a pseudo weakness, which is they are exhausted and they wake up the next day and they fall because they exercise too much. Did they mention risk of falls as an outcome of risk of exercising?
Just going from memory, I don't think, and this was one of the things we were interested in, none of the studies really looked at balance exercise or balance retraining. And I don't think any of the studies looked at the rate of falling. I can check that for you and be 100% certain, but I think that was a real gap in the study. We didn't have much information about falls.
I have a question online.
Well, it actually follows that beautifully, because it was, did your research find any trends about exercise reducing falls or other harm?
Yeah, I think this was really interesting. We expected there'd probably be a balance training category when we were first thinking through how we'd categorise the data, and balance was never the primary intervention. Some of the mixed interventions included a balance training component, but again, the outcomes weren't really clear enough for us to know how balance training affects falls risks or how effective it is.
Question here.
Thank you so much. It's really important to bring these topics to consideration. I always love it when someone comes with an exercise retrospective or looking at the literature. The Clausen paper actually did look at falls, and so you might go back and take a look at that. I think they did show an increased number of falls in the individuals that were randomized to the resistive training arm. It was not statistically significant, as I recall, but they did show that there was maybe a potential trend there that Eduardo might be from what you were recalling. I think these studies are incredibly difficult, and partially again because when we randomize these individuals to different types of exercise, again, the type of exercise any one of us likes to do is very, very different. And so again, in that Clausen paper, they were randomized to either stretching range of motion, resistive, or an endurance exercise, and that was done completely at random. So somebody who might have loved going to the gym all of a sudden was randomized to a stretching protocol, and again, that adherence there may be incredibly difficult. And so I think individualization of these exercise programs for these individuals and having that personal talk like you're describing, what do you like to do, what type of exerciser have you been? And as opposed to thinking about what might help, I think it's always important for us to know what might hurt and flip it in that direction. So what might be damaging in some of these exercise regimens and some of the high intensity, what types of strains, what types of respiratory training might not be advantageous for this population, I think is a critical question that we need to answer, as what type of exercise is best still hasn't been answered for the larger population in general. And so for us to tackle that in an MND-ALS, I think is a huge task. But thank you so much for bringing this to the table today.
Thank you. We have a question online, and then we'll go to Helen.
Should we be looking at measures like ALS FRSR? I don't think we anticipate exercise improving scores, but should we be looking at more quality of life measures or measures that look at specific tasks, like the Berg balance, the 10-meter walk test?
I think we should probably ask people with ALS-MND what their priorities are. I think working clinically, some people really focus around the functional and slowing the decline of the disease element of exercise, but some people definitely look at symptom management, depression, managing their pain, managing their swelling. So I think there's definitely space for a qualitative study to look at what types of outcomes are a priority for people with ALS-MND. the ALS FRSR scale is nice for comparing studies with each other in future systematic reviews, so that's probably a good one to still include because it's so common. But yeah, perhaps we should be looking at different outcomes as well.
Lovely. Helen, do you have...
Lovely, thank you. And thank you very much. It was beautiful to see a systematic review and see somebody else stand up and say that, yes, you can exercise. I actually think that we need to move on from it now. We've had so many studies that say, yes, it's good to exercise, and this shows that it is good. I think we need to move on from randomised controlled trials. It's what people want to do. I think we need to move on from worrying about falls. The study that I did, people didn't fall. They actually were improved hugely 24 hours post-exercise. What people did do were decondition. So if we keep asking, should we be exercising, we actually risk deconditioning lots of people. So brilliant to hear this. I think now we look at individualise what people want. And the other thing, sorry, and then I'll be quiet. I think it's very important for us to think that a lot of the people that we treat have had lots of exercise before diagnosis. This is their usual phenotype. It could also be their genotype. The worst thing we can do is stop them exercising when this was their normality. Thank you for doing it. Appreciate
Thanks, Helen. I really liked that question. I guess one of the big things that we did identify in this review is that there is a lot of information for people at those earlier stages and with minimal impairments. But as the disease progresses, that still hasn't really been tested. So I think there's room for more information and evidence around there so people can feel confident across the whole spectrum of their disease making those decisions. But yeah, thanks for that.
We have time for one more question.
Okay. Hi there. I'm Paula. I'm a person with ALS, and I'm a former personal trainer and whatnot, kinesiologist. But one thing that might be interesting to look at for somebody in the room moving forward, I'm on a drug called tofersen, and I've actually had symptom reversal. So question I have, with people like this who are on this, when is the right time to start exercise? Again, probably any type of exercise, but how should that go and what are the expectations and whatnot? Might be something to look into.
Yeah, that's something that we'd love to know is how people respond as their disease progresses, as their muscles get weaker, as those muscles are more affected.
And
how
is there
they
a plateau?
Yeah, exactly. Yeah.
I'm loving these questions. There's actually we have one more for the lady. Yeah.
Fantastic. Just a quick comment to build on what's already been said. It's very easy to get excited about exercise. I'm a physiatrist, and I found it very interesting that you pointed out that 12 out of 16 of the studies that looked at resistance exercise had modified protocols, but we really don't have any strong evidence in humans to make those limitations on type of resistance exercises. So as I was sitting with a person with ALS in my clinic and providing some guidance on resistance exercises and the limitations based on the evidence that we have, this person asked, why don't we have the evidence?
Mm-hmm.
That shouldn't be very hard to study. And he was absolutely right. So I think this is a great framework for the studies that we should be doing and realizing how difficult it is with finding funding for that kind of study. But I totally agree. We should talk about what you can do rather than what you can't.
Okay. I think we have to call that a time now because I think people will be very keen to have a cup of tea. Claire, thank you very much.
Thank you.
So we're going to have a short break now, and for those people who are joining us virtually, please do step away from your computer and take a walk and have a cup of tea. And those in the room, the refreshments are outside. And could you please be back to join us at 3:35?